טוב, אז שלום לכולם, אחר צהריים טובים בישראל, ובוקר טוב בקנדה. אני מאוד מאוד מתרגשת להזמין להרצאה היום את דוקטור רבקה קולמן. היא מומחית לרפואת ריאות ורפואה פליאטיבית במאונט סיני ו-University Health Systems, כאן בטורונטו. היא assistant professor, אין לזה תרגום מדויק בעברית, למחלקות לרפואת ריאות ורפואה פליאטיבית באוניברסיטת טורונטו. היא השלימה את ההתמחות שלה ברפואת ריאות, פלושיפ קליני בהשתלת ריאות ורפואה פליאטיבית. השלימה גם תואר שני ב-Quality Improvement ובטיחות מטופלים, דרך מכון ניהול מערכות בריאות וערכה, ואת כל אלה גם דרך University of Toronto. דוקטור קולמן מתמקדת בשיפור איכות החיים למטופלים עם מחלות ריאות סופניות, דרך העבודה שלה בתוכנית ההשתלות, ופיתוח תוכניות נוספות לתמיכה פליאטיבית במטופלים ללא מחלות ממאירות. יש לה 3 ילדים, בני 4, 6 ו-8, חמודים מאוד. היא אדבוקטית ופעילה ועם ערכה עמוקה לנזקים של עישון. היא מאוד פעילה מקדמת את השתלות האיברים וחשיבות של טיפול פליאטיבי מוקדם ומתן איכות גבוהה של טיפול סוף חיים. אז אני גם גאה שאני יכולה לקרוא לה גם חברה. דוקטור רבקה קולמן, the stage is yours. Good luck.
Thank you. I'm just going to turn my PowerPoint presentation on and then attempt to share my screen because I'm not as technologically savvy as some. Tzoharaim Tovim, that'll be sort of the extent of my Hebrew. Today, I can understand most, I think, of what you said, Shachar, but I'm quite embarrassed that my Hebrew has gotten a lot worse over the years. So I'm going to try to speak slowly. I do speak quickly. I feel like most Israelis can follow fast-talking individuals, but because it's a different language, if I am speaking too quickly, please slow me down. I also have tried to use generic names of medications wherever possible, but if there's some nuances with the Canadian healthcare system that don't necessarily apply, please just interrupt at any point in time. So it's a real honor to have been asked to give this talk today and speak to you all about palliative care and end-stage lung disease, and I call this talk Addressing the Gap in Care. I have no relevant financial disclosures, but I will discuss the off-label use of medications, including opioids, mirtazapine, gabapentin, pregabalin, amitriptyline, and cannabinoids. So my objectives today are threefold. One is to appreciate the range of symptoms experienced by patients with non-malignant respiratory disease, to discuss a practical approach to commonly encountered symptoms in this population of patients, and also to review the strategies for productive discussions and advanced care planning with these individuals, and just some of the nuances that apply to the non-malignant disease compared to cancer patients. And we'll start with a case. So Mrs. C is an 83-year-old woman who lived in a senior's apartment, and she was admitted to hospital with an acute exacerbation of her COPD, chronic obstructive pulmonary disease. She had pretty significant disease, so her forced expiratory volume in 1 second was 0.6 liters or 35% predicted. And she had other important comorbidities, including type 2 diabetes, hypertension, hyperlipidemia, osteoarthritis, and environmental allergies, and she had a past surgical history of a hysterectomy. So again, her medication, so if these names, I know sometimes they're a little bit different. So she's on umeclidinium, which is a long-acting muscarinic antagonist, budesonide formoterol, which is the inhaled steroid, long-acting beta agonist combination puffer, salbutamol, I don't know if you call it albuterol, which is the short-acting beta agonist, the rescue inhaler. She's on an angiotensin receptor blocker, a calcium channel blocker. She's on insulin for her diabetes. She was on deep vein thrombosis prophylaxis in hospital, not at home. Calcium, she's up to date with her influenza vaccine and her pneumonia vaccine. And this was pre-COVID, so she hadn't had a COVID shot. But again, pre-COVID, there was no such thing when I saw her. This was 2018. And in hospital, she was actually quite sick when she came in. She was admitted to the intensive care unit and had a short course of non-invasive ventilation. And in Ontario and Toronto specifically, really that therapy only happens either in the emergency department acutely or in an ICU. and she'd received systemic steroids and bronchodilators, and she sort of got over that acute part. But she was so dyspneic that she couldn't get out of bed. And so she was assessed by the respirology service, and they had trialed theophylline, which we almost never use, I would say, in respirology. There was one of the older attendings that had seen her and had tried it for her dyspnea, and that was really poorly tolerated. It didn't make much of a difference. It was stopped. And she didn't qualify for supplemental oxygen. And so I apologize. I should have asked before, but in Ontario, there are very specific criteria for supplemental oxygen to be covered by government. And we know in some COPD patients that increased, that they don't, if they don't qualify for oxygen can actually be quite dangerous for them. And she didn't. And that's very common, that our patients can be really dyspneic and yet have normal oxygen saturations. And so they asked the palliative care service to see for symptom management and for planning, like, where's this lady going to go who was previously living mostly independently and now couldn't get out of bed? And I happened to be on service, which was lucky for me. And I approached her, and she was there with her daughter, and she said, I don't want to see palliative care. I'm not dying. And I know I'm speaking to a group of palliative care clinicians right now. And I just still find it amazing how often I find myself explaining what I do to both patients and other clinicians who are not in palliative care. Because I think still, especially in the non-malignant world, people find it really hard to reconcile that we might be involved. And again, I think this reluctance to accept palliative care in non-malignant disease is again, not experienced just by our patients, but by a lot of healthcare practitioners. And when we think about why, I think, people in 2022, they don't really bat an eye when people have advanced cancer and someone's referring them to palliative care, at least not in Canada. People see cancer as associated with a high symptom burden. And I think most people know that cancer is life-limiting. But when we think about organ failure, and sort of you can superimpose any, I don't know if my cursor's showing up, but any disease on this, in this category, whether it be chronic obstructive pulmonary disease, interstitial lung disease, cystic fibrosis, pulmonary hypertension, which are the four that I mostly deal with, and then the weird and wonderful, lung diseases as well, but you can superimpose advanced heart disease, chronic kidney disease, frailty, dementia in this category. And society doesn't really view it as life-limiting necessarily, despite the fact that COPD is the third leading cause of death across the world at this point. I mean, COVID may have surpassed it, over the past few years, but if we think about chronic diseases, certainly. And then we even think about sort of the language that's used in medicine. Now, I don't know the Hebrew language that's used, but when we think about cancer, we talk about cancer progression. And when we think about these lung diseases, we talk about flares or exacerbations. And even in the language, it implies that you're going to get better, that you're going to get over it. When we teach in our medical school system, when we teach breaking bad news to medical students and to clinicians, it's always a cancer case. It's never COPD. It's never interstitial lung disease. And those sometimes may have a worse prognosis than cancer. And so, I think it stands to reason why people sort of find it so difficult to actually understand why palliative care might be consulted in these cases. And I remember, I think, Shahar, you were on service when it was in the middle of COVID, and I was sitting in rounds with a bunch of clinicians, and I said, maybe we should get involved in some of these patients. Oh, no, don't. And I had to look at them and I say, well, we're not the do not get better team. Like, we're not the you're not allowed to get better team. We're not the do not resuscitate team. We're the team that helps to improve quality of life of patients and help their families dealing with life with sort of life-limiting illness, non-curable illness. And so I refer back to this World Health definition all the time. And the three features that I like most are that we intend neither to hasten nor postpone death, that we integrate the psychological and spiritual aspects of patient care, and that it's applicable early in the course of illness and in conjunction with other therapies intended to prolong life. Now, it's really easy for me. I have a crutch, and I say to people, listen, I'm a respirologist. And I'm a lung transplant doctor. And we use these therapies and these interventions in people that are moving ahead with transplant. And I feel that gives me a little bit of what we call street cred. But I don't know that that's fair. And I always feel a little bit guilty that I sort of use that, because I shouldn't have to. People should understand that palliative care doctors, or palliative care interventions can be applied early and really help people live longer. And I swear, I can tell you lots of stories, and sometimes I have to use them, not you. I don't need to tell you, but patients and other clinicians of how we really have helped patients actually live longer, even though that's not the primary purpose. But when we make people feel better, they tolerate their other therapies better, and they often live longer too. And there's lots of studies that show that. So I stole this diagram from the heart failure world. There's something similar in both the American Thoracic Society guidelines about the management of advanced lung disease and also in the Canadian Thoracic Society guidelines, but I like this picture better. So if you ignore onset of CHF in the diagram and you just think about somebody's lung function, or you can apply this. This is what's nice. You can apply it to other diseases as well. And so quality of life is the red on top, time is along the x-axis, and then purple is palliative or supportive measures, and orange are your curative or disease modifying therapies. So at the onset of somebody's disease, you pick the disease, their quality of life, their lung function, their ejection fraction, whatever it is going to be quite low. And this is where somebody's piling on curative or disease modifying therapies, and they might need a little bit of symptom-based care. And then this can go on for a long time. And these hatched lines indicate that this can be indefinite. It's funny that in so many of these diseases, they might be at risk of sudden death. So that's the context of a massive COPD flare, an interstitial lung disease exacerbation, a heart failure exacerbation, cardiac arrhythmia, and someone with sort of a big area of scar and poor ejection fraction. So that can happen. And then, but they might stay stable for a while. And then again, pretty common that they start to get into this. Advanced liver disease fits in here too, actually. So they start to get into this cycle that anybody who's sort of been a hospitalist or an internal medicine service has seen, where they start flaring. And their symptoms start to pick up, and they're in and out of hospital a little bit more frequently. And this is where you would probably augment both your curative or your disease modifying therapy as well as your palliative measures. What's special about heart disease is this orange oval, which is sort of where they're considered for advanced therapies, either ventricular assist devices or transplant. In lungs, we have the same thing. This is where you would consider lung transplant in patients in this series of decompensations and exacerbations. And if they're not candidates for transplant or these advanced therapies, then they would progress to end stage disease. And that's often where these, symptom-based therapies would take over. And this diagram shows that these curative or disease modifying therapies might taper off. But I think in non-malignant disease, what's different than in cancer therapies is that we're really not de-escalating therapies in the same way unless the healthcare systems don't cover. So in the US, when you decide to go for hospice or palliative care through Medicare, all of a sudden, if you're on social assistance or you have government payment for some of your therapies, they will no longer cover a lot of your disease modifying therapies, which can be quite problematic. In Canada, thankfully, that's not the case unless you need to go into a hospice or a palliative care unit. And I know that we have more of those in Canada than we do in Israel. But similar to Israel, my understanding is that to get into a hospice or palliative care unit with non-malignant disease is quite challenging. It happens, but the vast majority, probably over 90% of our palliative care unit and hospice admissions are for malignant disease in Canada. What's really nice, I don't show this in this diagram, but in the American Thoracic Society diagram, is that palliative care helps and continues on beyond death to support the family through bereavement. So we know in lung disease, and again, in lots of non-malignant disease in general, that there's really a substantial unmet symptom burden and psychological concerns that affect both our patients and their families. And in the respirology world, where we're really deficient are in symptom assessment and management, and also in advanced care planning. And that's what I want to focus on today. Studies have shown that improved palliative care integration improves patient quality of life, patient and caregiver satisfaction, and lowers the cost of healthcare. So in Ontario, COPD is the #1 reason for acute admission to hospital, or was, and it's responsible for more healthcare spending than any other disease in the province. So COPD is #1 and heart failure is #2. So hopefully I'm never going to be out of a job. And so huge costs, though, to the healthcare system, especially in a publicly funded system. And professional societies around the world, the CTS, Canadian Thoracic Society, was probably one of the first that advocated for palliative care integration and use of opioids for patients for relief of symptom burden in those with advanced lung disease. And so we often think of shortness of breath and cough in lung disease patients. And again, this is a talk for palliative care clinicians. And so maybe, we recognize that there are a sort of a wider disease or burden of disease, a wider spectrum. But again, if you haven't seen COPD patients quite as frequently as cancer patients, it is important to sort of capture their burden. And there's a number of studies that have looked at the burden of symptoms, and the mean is about 11 to 14 different symptoms experienced by patients with COPD. So if you move on to interstitial lung diseases, you find that it's the same. So yes, shortness of breath and cough, or dyspnea and cough, are the most commonly experienced symptoms, followed by anxiety and depression. And I always talk to my patients, are always amazed when I talk to them about the mechanisms of dyspnea and where dyspnea comes from and the pathophysiology, and how the limbic system and the amygdala are intrinsically linked in the brain to the breathing center. And so shortness of breath begets anxiety, and anxiety begets shortness of breath. And sometimes just explaining that to people, sort of all of a sudden they feel so validated about their panic. A lot of them have GI symptoms, and often that's related to some of the medications that they're on. People can get insomnia, anorexia, fatigue, and pain in the interstitial lung diseases. Pulmonary hypertension. So I've transposed this long laundry list of symptoms in writing onto the side here, just so you can see. But again, huge spectrum of symptoms that are experienced by these patients that we might not necessarily consider. And so this was a study that looked at sort of patient symptom reporting over 3 days, where they had actually indicated that their symptoms were moderate to severe. And in cystic fibrosis, again, the list is extremely long. I've had to transpose in bigger writing again, just to see, but these are young patients. They have a huge burden of care just from their therapies. On average, they spend over 2 hours a day just to try to get themselves going. And they also have all of these other symptoms on the side. So the problem in non-malignant disease is that we actually don't have a validated tool that allows us to capture the range. So there are like in the more than a dozen. So there are in the sort of, probably over 40 tools that evaluate different aspects of patient symptoms. Most of them focus on their breathing or their functional status, their exercise tolerance, their cough. If you actually had to administer all these tools, it would take a patient an hour or longer to do each one. So I borrow shamelessly from the cancer world. And in Canada, we really rely on the Edmonton Symptom Assessment System. So Eduardo Pereira created this when he was in Edmonton. He's now at MD Anderson, but it's validated in cancer. I know it's not validated in lung disease, but it really is a really nice snapshot of how we can sort of understand what these patients are experiencing and have them rate it and know where to focus our care. And to the regular ESAS, I've always added cough, because it's not actually part of the sort of regular ESAS, and constipation. And then sleep in dip. So drowsiness is part of it, but sleep quality isn't always part of the regular original ESAS. And so those are sometimes the ones that I add on just to get a better sense of where they're at. And what's really lovely about the ESAS that I've always really appreciated is it gives you this opportunity to say to a patient, is there anything else that I haven't asked you about in my standard symptom screen that you want to talk about, or that you're finding really frustrating or affecting your quality of life? And they can rate that, and you can try to target that in your therapy. And then how do we treat symptoms? So again, this might seem obvious, but where it differs than in the cancer world, again, is that there's this focus in cancer and in advanced cancer often on de-escalating therapy, on reducing disease burden when sort of people have sort of reached a certain point in their treatment or in their disease course. But in the non-malignant disease, and specifically in a lot of the lung diseases, you really want to optimize their disease-specific treatments, because most of the therapies that are designed to treat the symptoms and extend life actually also play a role in symptom management. I would say with the caveat of the antifibrotics, they're pretty terrible evidence that in interstitial lung disease, antifibrotics actually help people feel better. I didn't put my slide about antifibrotic side effects into this talk. I probably should have, but they're pretty horrifically tolerated. And so that in that case, it's about talking to the respirologist about, potentially de-escalating or reducing doses, taking drug holidays, or even stopping. And then we go to non-pharmacologic management, and then we think about the pharmacologic management. So again, the Canadian Thoracic Society was probably one of the first to really come out with guidelines. The guideline is old. I'm almost embarrassed to put it in because it's from 2011 and it really hasn't been updated. Although there are other sort of world societies that have sort of come close and started to recommend things, there really aren't guidelines yet. This comes from COPD. So they don't all apply to the spectrum of lung diseases, but I would say that for the most part, things that were recommended for COPD care can be applied to some of the other lung diseases and the non-malignant lung diseases. So from a non-pharmacologic perspective, neuromuscular electrical stimulation and chest wall vibration, as well as walking aids, received a level 2B recommendation. So low level of evidence. So none of them are that exciting, to be honest, but they got in there, and pursed-lip breathing as well. I have never seen neuromuscular electrical stimulation and chest wall vibration done. I don't apart from in an ICU setting in patients recovering from sort of critical illness, neuropathy and critical illness, myopathy. That's where I've seen the neuromuscular electrical stimulation, but I don't even know where to get it as an outpatient for patients in Ontario. Walking aids and pursed-lip breathing, those are the ones that are particularly designed for COPD patients, and there's a real physiologic reason for it. So in COPD, people are hyperinflated, their diaphragms are flat, and that puts you at a mechanical disadvantage when you're breathing. So when we talk about a physical exam for someone with COPD, we always, are they tripoding? Are they sort of, you can't see where my hands are, but often you see these patients tripoding and sort of trying to stabilize themselves on their knees. And what that does is it actually restores their chest wall, and it helps. It restores them to a better mechanical advantage. So a walking aid does the same thing. So our patients will say, oh, I can do better when I'm in a grocery store or with a walker. And pursed-lip breathing provides some auto positive end expiratory pressure that allows patients to actually exhale more fully to then be able to take another breath in. In interstitial lung disease, those things they're not the same, right? Their diaphragms, if anything, are almost pulled up more because their lungs are retracted, they're fibrotic. So they don't need, to necessarily brace themselves and sort of expand their chest in the same way. But walking aids or walkers are really, really helpful because to me, I get them to use one of those rollator walkers, the kind with the basket and the chair. Because, it sounds really silly, but it's a place for them to put their oxygen so they're not lugging it around. And it keeps people active because pulmonary rehabilitation and exercise is a hugely important part of their therapy and of improving their quality of life and potentially getting someone to transplant if they're a candidate. And it gives them this instant chair. So if they can actually walk and then sit down when they need a break, and then they can get up and keep going. And then we often tell patients, so there's no specific way to breathe. So we tell patients just breathe however is comfortable when they have pulmonary fibrosis or one of the other ILDs or pulmonary hypertension or cystic fibrosis. There was no evidence to recommend any of these other therapies on the bottom half of the slide, but I would say that if it helps someone, why not? As long as they can afford the therapy. And a handheld fan, there are lots of papers on handheld fans. The evidence is not quite robust enough, but it's pretty cheap. We don't let people have them in hospital post-COVID, which is really frustrating that they can't bring in their own fans. But if it helps someone, why not? From a pharmacologic perspective, opioids are really the only pharmacologic treatment that has received any recommendation in the treatment of dyspnea, and it only got a 2C recommendation, whereas anxiolytics and antidepressants actually got a recommendation of a 2B against. Now, that's not to say don't use them, right? I think what's really important to recognize is that we talked about this dyspnea anxiety cycle. And if someone truly has anxiety and that's the driver of their dyspnea, then yes, you should use an anxiolytic or an antidepressant. But if it's primarily their dyspnea that's driving their anxiety, I find it better. People respond better to opioids than they do to anxiolytics. And I would also say that, you know, a lot of people are worried about CO2 narcosis. And I find that happens more frequently in patients using benzodiazepines, or when they crank up their oxygen too high and then they lose their hypoxic drive to breathe, than I do if I was to start an opioid in someone, and then supplemental oxygen for those who qualify. So how do opioids work in shortness of breath? And I apologize if this is repetition for a lot of people. There's this really great review, Jennings and Florax in 2002, and then an older one in 1995. But nobody completely understands. But it's thought to represent, or to be sort of probably a combination of these mechanisms. So they decrease the central perception of dyspnea. They do have some role in reducing the anxiety associated with dyspnea. They decrease your overall sensitivity to hypercapnia, decrease peripheral oxygen consumption, and improve cardiovascular function. And what's really lovely, and I'm not into the cough part yet, is that they also treat cough. It's like a sort of like a, you know, just like a one, I don't know, one size fits all, but you can sort of kill two birds with one stone is the expression we use. And you can, when in lots of our patients who have cough and shortness of breath, in cough, they decrease the overall sensitivity of your central cough receptors in your central cough center. It's this middle part, this decreased sensitivity to hypercapnia, that I think a lot of people worry about in lung disease. There was just, I'm holding my phone up, but we have a WhatsApp for all the respirologists in Ontario. And someone just posted last night about one of their patients who's actually allergic to inhaled steroids and has this horrific post-COVID cough. And someone else wrote, they should try low-dose opioids. And this woman wrote back, oh, but she's 80. And so I responded, well, that doesn't matter. You can still use a low-dose opioid to help manage their cough. Just start really low and go really slow and follow. But sorry, that was a slightly off topic. But again, the sensitivity to hypercapnia, I find is not a big deal. Someone who's overly sensitive to hypercapnia, that's actually a problem, right? That's where when you think about Cheyne-Stokes respiration in people with advanced heart disease, not necessarily same mechanism at end of life, but this apnea and hyperpnea cycle. So the not breathing with the crazy sort of overcompensation. This is sort of my hand motion for the hyperpnea cycle when they're really taking those massive, massive breaths. Why does that happen? That happens because they're too sensitive to a little bit of hypercapnia. And so then they go into overdrive, then they blow their CO2 down way too low. And then they stop breathing, and then they're in this horrific cycle. So what they have done in the sleep apnea, the central sleep apnea studies, is they've titrated in CO2 to make people less sensitive. Their kidneys can compensate. And what we often are called to do in hospital is actually give people opioids to then also decrease their sensitivity to hypercapnia a little bit. Then they stop Cheyne-Stoking and they actually do a lot better. That's interesting when that works. And so I just try to tell people it's really not such a big deal and you can watch people. So these are the studies that I often end up talking about. And I present them for palliative care colleagues, and I also show them to my respirology colleagues. They're smaller than in other parts of it. They're smaller than cancer studies. They're smaller than heart disease studies. So Curro, this is a Canadian study. He looked at patients with refractory dyspnea. 45 of them had COPD. A mean daily dose of morphine of 14 per day, so pretty low. They found no episodes of respiratory failure or death. David Curro's not. He's Australian, I apologize. And this was heart disease patients and COPD. Graham Rocker is Canadian. He's out of Halifax. And this was all patients with COPD. Again, looking at the use of low-dose opioids in treating their dyspnea, no deaths attributable to opioids. And then these are the two larger studies. So both out of Sweden. Engström was involved in both of them, Magnus Engström. So the first was in COPD patients. And what they found was that low-dose morphine of less than 30 milligram equivalents per day was not associated with increased admission or mortality. And all of them were COPD patients on oxygen. So where the biggest concern of this, CO2 retention sort of exists. And then 4 years later, they published a similar study on interstitial lung disease patients, all on oxygen. And they found that both less than 30 and doses of higher than 30 equivalents or milligrams per day of morphine were not associated with increased admission or mortality. And sort of a colleague and I wrote a response to this first one, the COPD one, this issue of doses of over 30 milligrams were associated with increased mortality. It's impossible in these population-based studies to rule out confounding by indication. So we know that patients at end of life probably need higher doses of medication, maybe more tolerant, and that symptoms are a sort of an important prognostic factor and correlate with mortality. And so I think it's impossible, these patients who needed higher doses may have been dying anyway. And so that they need higher, it wasn't necessarily the dose that was causing their mortality. They were dying, hence they needed higher doses. And there's really no way of teasing those apart. So I would say that I try to stick to 30 in someone who's 30 or less than someone who's well and early in their disease or has no signs that they're really declining and approaching end of life. But if you need to go up on the dose in end stage disease or when people are really approaching end of life, that's okay too, because it's not the opioids that are killing them. So there are challenges. So I know we have better access to opioids, I understand, in Canada. I think we're the #2 prescribing country of opioids in the world. And I think we get slammed a lot by the opioid naysayers that were sort of contributing to this epidemic. But there are still challenges in prescribing them to our patients with lung disease. And that's because there's really a lack of clear guidelines about how to start them, how to titrate them, how to monitor them. What side effects come from what, lots of people, I started my opioid and then my sputum got worse and I started getting more short of breath, therefore it must be the opioid. No, that's your exacerbation, but it's sometimes hard to convince people otherwise. There's a lot of resistance, both from the patients and from clinicians because of the risks of respiratory depression and the risks of addiction. And I find it really challenging in patients with baseline opioid use to know you're supposed to, if someone has chronic pain or is on an opioid for another reason, to treat their symptoms, you're supposed to go up by 25 to 50% to treat their new cough or their shortness of breath. That can be a really big dose of opioid. And if you're not seeing them all the time, if they're not in the hospital right in front of your nose, it can be a bit uncomfortable to prescribe that much opioid, I find. And then different places in Canada. So we're in Ontario. You can kind of prescribe anything you want, and there's no sort of limitations on who can prescribe. Nurse practitioners can also prescribe. In different parts of the country, you need a special license and a special type of prescription pad to actually prescribe an opioid. And so it's very limited. So what we do, and I mean, this is sort of the same, I think, is how I would start opioids in cancer, is we start morphine at an immediate release formulation at about 2.5 to 5 milligrams. The lowest dose we have available by tablet is 5 milligrams, so it's half. If we want to go lower, you use the liquid. In the CTS, the Canadian Thoracic Society guidelines, they actually suggest starting at 0.5 milligrams or 0.5 milliliters twice a day, and then titrating up by 0.5 milligrams per week. So to me, you'll just lose everybody's sort of belief that you're actually going to help them in any way. We follow that same dose every 4 hours as needed, or more frequently, maybe every 1 hour if they're reliable, and then try to get them on a controlled release formulation. I find this helps a lot with people with chronic cough. Sometimes people with dyspnea really don't respond to the long acting, in which case then I would keep them on their short acting. We always talk about the side effects. Again, this is a palliative care crowd. We don't have to go through. And the only difference here than maybe in cancer patients is that I almost never omit my laxative, because the worst thing I can do to someone who has lung disease and is short of breath or has bad cough is make them constipated. They strain, they valsalva, they decrease the venous return to their chest. They can become hypoxic. I've seen someone, not under my care, but when I was a trainee on the respirology service with pulmonary hypertension, she basically had sort of defecation syncope, fell off of her commode, became hypoxic and died while she was waiting for transplant. The only time I wouldn't do it is in someone who's on an antifibrotic, nintedanib being the one that causes more diarrhea. And if they're already having so much diarrhea, then the opioid can actually help manage their diarrhea. And then I just warn them they might get constipated, and we follow up regularly. And when we studied this in our pre-transplant population, we found that there was a trend towards increased exercise tolerance and a timely discontinuation of opioids after transplant. There's a lot of transplant programs around the world that are still not allowing patients to be on opioids or benzodiazepines while they're waiting for their transplant or while they're listed. And to me, I feel like that's cruel, unusual punishment, because these people need to exercise. They need to sort of be functional. They need to show that they're robust and fit enough to get a transplant. And yet you're sort of removing the tools that they might have available to actually start to feel better and participate. So thankfully, Toronto is not one of those programs. So back to Mrs. C, we did exactly that. I started her on a 2.5 milligram test dose. 4 days later, she was using it about 4 times per day. So I put her on a controlled release 10 milligram in the morning and 2.5 milligrams before her physio. You don't have to put them on twice a day. So they don't need round the clock opioids if they're not moving around at night, if they don't have bad cough. We treated her, I moved ahead. We treated her bowels. And actually, she was discharged from hospital 3 days later. So she felt well enough to get up and start moving. They set her up with a home visiting palliative care team who could continue to prescribe her opioids. And after 16 months, she was still attending pulmonary rehab 3 days per week, and she was on the same opioid. So a lot of people think, I'm going to start this and I'm not at end of life. I don't want to be on opioids yet. I'm not ready for that. And it's just my needs are going to increase and I'm going to end up addicted. But, we can show that, some people's needs don't actually change over time. So when we think about coughs, that was a lot on dyspnea. It is sort of near and dear to my heart. I tell people that cough is the hardest thing that I manage. And I don't know that differs in cancer-related cough. I find that I think a lot of people who has really refractory cough related to their cancer, you end up really needing to sort of snow them with medications unless others have other tools, which I would love to hear. But especially in our lung disease patients, we want to consider reversible causes. So think about asthma. Do they have reversible airways obstruction? Should they be on a puffer? And if they shouldn't, you can actually, a lot of people are started on puffers and that's just like an extra thing that they don't need to worry about. Postnasal drip, we can treat reflux. And then medications like ACE inhibitors, we can switch them to an angiotensin receptor blocker. Opioids really are first line for cough for the reasons because they decrease that sensitivity at the central cough center. And what I tell people is, again, it's about sort of setting expectations. I really usually cannot get rid of someone's cough if there's not if it's a refractory cough for whatever reason and you can't really find the underlying cause. But if you can make it better, cough begets cough. And so the more you cough, I always talk about sort of an itchy mosquito bite. I don't know how bad mosquitoes are in Israel, but here they're bad in the summer. And so the more you cough, it's like sort of scratching and irritating that mosquito bite. So even if you can sort of make it just a little bit better, then that on its own will decrease the frequency and the severity of the cough. You can use neuromodulators like gabapentin, pregabalin, and amitriptyline, and they'll sometimes work. I find that they often will make people really sleepy, more so than the opioids. In the guidelines, in the cough guidelines and in the interstitial lung disease cough guidelines, they talk about multimodal speech pathology therapy, which is a combination of cough education, vocal cord hygiene, and like swallow techniques, antitussive. So I find they don't really work. So dextromethorphan, if you read up to date, those experts also say don't use dextromethorphan. People are always come to me on them. And if they say it works great, they can stay on it. But I find I never would start it on someone not on it already. And then the expectorants and the mucolytics like guanfacine, I also don't find it works. But again, some people live by it fine if they want to, and I don't bother stopping it. N-acetylcysteine or NAC can be helpful with chronic bronchitis. It's actually part of our guidelines now, and it can act as a little bit of a mucolytic and decrease the sputum burden. It doesn't work for most people, I will be honest, but some people love it, and that's fine. It's not covered under any health plan in Canada, so they're buying it on Amazon. There's a million different products because they're getting it from a healthcare store, and I don't really have like a specific one to recommend. And this is oral. This isn't sort of inhaled NAC. Inhaled lidocaine, there are protocols for inhaled lidocaine when someone has really terrible cough. And again, the thought here is just the coughing begetting coughing phenomenon. So it just gives someone a little bit of respite. It basically freezes the upper airway cough receptors. And if that's what's triggering their cough, if you can sort of put those to sleep for an hour or two, maybe it'll sort of reset the balance a little bit. And then there are some newer studies on NK1 receptor antagonists and these PX23 antagonists as well. There was a lot of hype. They're sort of in the evolving or emerging therapies, but I haven't yet seen anything that's really that exciting coming out. And the cost of these medications are exorbitant, and they're not covered under any plans. Like the only time that NK1 receptor antagonist, like aprepitant is the one we have, is covered is in someone on really a metagenic chemotherapy. And so really it's almost impossible to get for people. The other thing that is sort of in the guidelines for interstitial lung disease is thalidomide. So there is some evidence that thalidomide reduces cough in patients with pulmonary fibrosis, but because of the side effects of thalidomide, it's also almost impossible to get. You have to apply in Canada federally to get permission for it, and I don't think anyone has the time or energy for that. So energy and sleep management in non-malignant disease, it's like we borrow a lot from the cancer world here. What I find is it's really important to validate their symptoms and acknowledge their symptoms. I think people expect low energy in cancer, but may not expect it as much in COPD and in interstitial lung disease. I learned this from one of my patients. They got this from their pulmonary rehab program. They were told, you've got a bottle of energy per day, a jar, and you can choose to use it how you want. But once the jar is empty, it doesn't get replenished till the next day. And so this I find very important for my patients who are listed for transplant and are needing to participate in their physiotherapy, or they're going to get delisted. I say, listen, sort of nap. It's okay to nap. And I say this with their families. Yes, we want them to exercise, but we also need them to rest, to conserve energy. And I think it goes a long way. Pulmonary rehab, again, this is where I struggle. So as a respirologist, I know, and as a palliative care doctor, that, use it or lose it. The less you do, the less you're able to do. But if someone, depending on where they're at and depending on what their goals are, it may not be worth it for them to get up and go for those walks every day. And so it's a discussion. Sort of the same thing I have with them about smoking cessation, right? I know that their smoking might increase someone's risk of exacerbation and make their lung disease a lot worse, a lot faster. But if they don't care, or they want to keep smoking, or smoking is really important to them, fine, they can smoke. I can't believe I say that as a respirologist, but it's true. So for poor sleep, similar, we use a lot of mirtazapine because it helps people's, anorexia, sometimes their nausea, but often we think about sleep disordered breathing. So maybe I'll send someone for a sleep study, but otherwise it's very similar to the cancer world. For nausea, again, it's sort of etiology guided, same as in cancer. But the one thing to think about is that a lot of our therapies, a lot of our disease modifying therapies cause a lot of GI side effects. So the antifibrotics are classic for causing anorexia, diarrhea, nausea. And this again is where, yes, it might be keeping someone's lung function maybe a little bit more stable, but if it's destroying their quality of life because they can't eat or they're always on the toilet, it's worth a discussion with their respirologist. We don't use very much phosphodiesterase 4 inhibitors in Ontario because there's one on the market, roflumilast. So this is a treatment for chronic bronchitis. And it really reduces the frequency of exacerbations and helps people with their cough and sputum production. We don't use it a lot, one, because it's not covered, it's quite expensive, and two, because of the GI side effects. But in the people that tolerate it, it can be life-changing. But think about it if someone has lots of GI side effects, and then we, as I'm sure many of you know, I get very frustrated when people tell me that metoclopramide causes QT prolongation. Maybe it can, but it's rare. We follow their QT because they're often on other medications like chronic azithromycin or other things that might prolong their QT. And then for constipation, again, we talked about this a little bit. The things to know here are, I'm much quicker to start someone on a laxative than if they had cancer. It's also sort of, I put it standing instead of just as needed. And stimulants don't work in cystic fibrosis. So in cystic fibrosis, their mechanism of diarrhea is the same as it's the same mechanism as when they get distal ileal obstructive syndrome. Basically, it's the equivalent of meconium ileus that babies experience. And so they get like rock hard stool from this lack of water in their gut. And so you really need to use osmotic agents as your first line if you're treating someone with cystic fibrosis and constipation. And often they may need more than just the polyethylene glycol. We need like Go Lightly or real sort of bowel prep to clear them out. So where does cannabis fit in? So there was one lung transplant clinic that I was staffing, so not from a palliative care perspective, but in my lung transplant part. And 3 patients on the same day, you know, all asked me about the role of cannabinoids in management of their disease. And so, you know, we know that there are sort of emerging evidence about these, you know, positive therapeutic effects, especially in palliative care in different areas of both THC and CBD, which are the 2 sort of active components that we think about in cannabinoids among many. Where I've seen most success for my patients are as an appetite stimulant and as an anxiolytic or an antidepressant, and pain, I guess, as well. But people are always asking, well, is it going to help my breathing? And it's interesting. So there were some studies from the 70s and 80s that showed that smoking marijuana actually had a bronchodilatory effect. And so I think this is where marijuana got a lot of hype. And so there have been some studies, there's not many, but there are a few looking at the role of cannabinoids in respiratory symptoms. So Pickering studied 9 patients. So these are tiny trials. It was a double-blind, randomized, placebo-controlled crossover study, 5 healthy and 4 patients with COPD. And they actually found that there was really no impact whatsoever on the visual analog scores for breathlessness. But they did say that the COPD patients shifted when they talked about the qualitative aspect of their breathing from describing it as air hunger to describing it as more sort of work or effort to breathe. And the authors of this paper interpreted this as a positive finding. So maybe it has some role. I don't know if I buy that, to be honest. And then more recently, Abdullah, so this is the group in Montreal. So Montreal is one of sort of the meccas of pulmonary rehabilitation in Canada, led by Jean Bourbeau. And they looked at 16 patients, gold stage 3 or 4. So those are patients with FEV1s of basically 50% or less. So quite severe COPD. They used vaporized THC, and they found no effect on exertional dyspnea, exercise tolerance, or airway function. So they had people doing repeat pulmonary function testing and spirometry, but they did find a significance in the rating of anxiety. So again, no role for respiratory symptoms, but maybe may play a role for anxiety. And in someone who's really anxious, it might be worth it. So again, I'm a lung specialist first and foremost, and I really can never see myself recommending that someone even like smoke. And even I've struggled to tell people to vaporize marijuana. And so I tell them if they are going to use it, they should use edibles or oils, because marijuana and cigarettes, yes, they might be a little bit better than cigarettes, but they still contain particulate matter. They might be mixed with other things. There are still toxic gases, reactive oxygen species, and polycyclic aromatic hydrocarbons, which are carcinogens. So yes, it might be a little bit safer than cigarettes, but not always. Vaporizing it does help reduce some of those negative effects. So you have to buy like these medicinal vaporizers, but I always say just stick with edibles and oils if you're going to use it. And vaporizing and smoking is associated with increased cough, sputum production, wheeze, and dyspnea, even if it's not necessarily damaging your lung function. All right, we don't have that much time, but I think if hopefully this part of the talk will be a little bit shorter. So advanced care planning and goals of care in advanced lung disease. So it isn't that different than in patients with cancer, but I find that, and the studies have shown that patients with these non-malignant illnesses are often less involved in their decision-making than those with cancer. They don't always associate their symptoms with their respiratory status or decline in their overall function and their end organ disease. Many of them would want less medical treatments at end of life, but they find it hard to reconcile because, again, they have this history of recovery from exacerbation. So when are they actually getting to that point? It's really hard to tell sometimes. And they also, like I said, they have this history of recovery from exacerbations. And the last piece is that it's harder to get really optimal palliative care in Canada for patients with non-malignant disease, because a lot of our funding and a lot of our resources are tied to prognosis, and it's a lot harder to prognosticate in someone with non-malignant disease than it is in someone with malignant disease. So what I find myself doing, like a huge part of my consults when someone is sent to me from a respirology colleague, even though my colleagues are fantastic and you can see in their notes, it says, oh, we've discussed their illness, we've discussed their trajectory, patients show up and they really have no idea what their disease means. And so it's about explaining their disease. And so one thing, again, I think this is probably familiar, and Shahar explained a little bit about how sort of goals of care and advanced care planning works in Israel, but I find it, I do a lot of time explaining sort of to respirology colleagues that, what the difference is. So goals of care discussions and treatment are like basically about part of treatment decision making. So when a treatment is actually needed and you have to ensure the illness is understood, then you try to align their goals with the approaches and with the options available. And it's not just a code status discussion. Advanced care planning is sort of everything we do to prepare the patients for their decisions that need to be made. And again, what's common amongst these two is ensuring that the illness is understood. And that's that's really where I focus my time. What's nice is that no matter what the disease, sort of usually the trajectories are similar. I find I'm always jealous of my cardiology colleagues who do palliative care, because everything flows to end stage heart failure, and sort of the treatments are the same, whether it be congenital heart block, whether it be a cardiomyopathy, ischemic, non-ischemic, everybody ends up with heart failure. In lung disease, end-stage interstitial lung disease looks different than end-stage COPD, which looks different than end-stage pulmonary hypertension. So the treatments are different, but the discussions are not different. The discussions are actually quite similar. And the line I often find myself using is, you've got a chronic disease, it's not curable, it's getting worse over time, and you're also at risk for flares or exacerbations. Those flares or exacerbations may respond to therapy, but may also be life-limiting, and may also take you from one baseline or one trajectory of decline, to another. And we see that all the time. Someone sort of declining, sorry, my background's blurred, but someone's declining like this on this kind of a slope over time. And then they have, later in time is on this end. And then they have their exacerbation, and they don't die from their exacerbation. You can sort of curtail their decline a little bit, but now when they get out of hospital, instead of declining like this, they're now declining like this. And that happens all the time. I'm going to skip this slide. The point I always make is that even from a palliative care perspective, this is an iterative process, and it's lengthy, and often depending on where someone is in their disease, they may, there's different parts of the conversation, and they might feel differently. So this is what our colleagues in Ontario are working on in terms of advanced care planning. I'll show you the reference. There's a fantastic reference both for patients and for healthcare providers that sort of take you through detailed goals of care discussions and advanced care planning for both healthy people with chronic disease or people with serious illness, depending on where they are in their disease trajectory. And really, this again harkens back to this whole issue of disease understanding. So preparing yourself for this conversation. And this is where, if you're not as familiar with someone's disease, you would speak to the respirologist or their specialist and try to figure out what was offered, what was not offered, and why different therapies might not have been offered. And then we would explore with the patients their understanding. And again, I'm always shocked by somebody says, well, nobody's really told me what's happening, and I don't really understand it. Even if they've been told, they really haven't heard it. So we spend a lot of time on this exploring and informing part, where I talk about their advanced, their progression and their risks of flares. And then we ask people what's important to them, and do they have any fears? And then we can make recommendations about therapies. And where I differ, so when I think about, the two most common patients I see are COPD and interstitial lung diseases. In COPD, I find it very hard not to recommend resuscitation unless somebody, if somebody really doesn't want to be intubated, fine. But if someone really does want to be intubated, I don't usually argue with them that much, because there's very poor data that helps to determine who is going to come off and who isn't going to come off a ventilator, even if they have horrific lung function. Yes, if they're bedbound and have no muscle function, they're probably not going to come off a ventilator. But if they have an FEV1 of 20%, they might still recover with treatment. And so if that's within someone's goals to see how they do, it's more about talking to their substitute decision makers about sort of the extent of therapy and when to withdraw. if that's an option, versus my interstitial lung disease patients where the guidelines actually recommend that if they progress to end-stage disease and there's no hope of transplant from a vent, that we do not intubate them, because the chance of them actually coming off is probably 0. I'm going to skip these. This is the site. So it's www.advancedcareplanningOntario.ca. And then there are there's an offshoot for patients. And this is part of the patient workbook that they can work through. It's in English. It's not in Hebrew. And then there's a separate link for clinicians to go through the advanced care planning discussions and how to lead them, and some other educational tools that I find very helpful. They were just modified actually recently. So in summary, patients with non-malignant lung disease often have a really high burden and wide range of symptoms. And so getting a comprehensive assessment of these symptoms helps to treat them. Opioids are indicated effective and safe in the management of respiratory symptoms. And when we think about advanced care planning and goals of care discussions, I find that a lot of these patients often are less aware, have less insight into their disease and what's coming for them and how to respond. And all of these discussions can be very helpful. Advanced care planning isn't the same as goals of care discussion, is not the same as a treatment preference or code status discussion. All are important at various different times, and there are helpful resources to guide you through. And that concludes the presentation.